I can hear you now, but
Yes.
you know what happened? Normally it's the university email I use, and that university internet. Sorry, that university internet for some reason not use my NHS internet. It's a bit slower, so I'm not sure whether it'll come
No,
through
I think
properly or not, but it should. Is it
no,
working now?
yeah,
Yes, sir.
there's no lag.
Can you
Everything is
hear me?
yes, everything is fine from our end, but we can hear you well.
So we are live.
Okay. Okay.
Yeah.
Good
Okay.
evening. Welcome to iFocus lecture 64.
Well, I
Today,
hope it goes through to the end.
right. Second of our international masterclass series. And we have Professor Harminder Dua, who will speak to us on applied anatomy of the cornea and relevance to corneal surgery and pathology. I would invite Dr. Mahipal Sachdev to make opening remarks. And then we'll have a short video of introduction of Professor Dua, and then he will start off with his lecture.
Thank you very much, Dr. Santosh, and good evening, everyone, and good afternoon, Dr. Harminder Dua. I think every one of us knows Dr. Harminder Dua, but I'll just wish to tell the viewers that Dr. Harminder Dua is somebody who has done India extremely proud. There is, I would say, there are very few ophthalmologists, or I think there wouldn't be any from the Indian subcontinent who has so many achievements to his credit. Dr. Dua started out from Nagpur, and I think he wanted to become a pilot, but ended up being a medicine person and an ophthalmologist at that. And he has worked at several places, and I think he has done extremely well as regards doing both clinical work as also work for the anatomy of the eye. And obviously all of us know that the Dua's layer is something that is named after him, which has gained acceptance now everywhere. Dr. Dua, apart from being the great clinician and a great researcher, I think he's somebody who's very, very humane, very humble, very grounded, and always willing to help. I think he's also a very emotional person, and he loves his country. And above all, I think he's a great shire. He writes very well and does a lot of poetry. So, Dr. Dua, it's always a pleasure welcoming you and having you at iFocus. We had you at Delhi, and it was always a pleasure to, even at that time, to listen to your journey as to where it was and what it was. Now, Dr. Dua will be talking about applied anatomy of the cornea. And as you all know, he's in England, and he got the one of the highest awards by the government or by the Queen of England only last year. And I think there's no other ophthalmologist who has got that. Apart from that, I would say that Dr. Dua loves to teach, and that is, a lot of us have gone and met him, and there are people who have done their fellowships along with Dr. Dua. Dr. Dua, as you all know, you have already been here. iFocus, we were doing a 7-day consolidated course, and we have done 8 of them. Since the COVID break came, we couldn't hold the physical meeting. So therefore, we started this online courses, and every Wednesday and Friday we have these lectures, and we have now started with the international masterclass. And yours is the second. Hafizi was the first that was on Wednesday, and yours is the second, and it's indeed a pleasure. And this is more than 60 of such lectures have happened. So all the postgraduates, the fellows, they are very keen to listen to you, and a very, very warm welcome once again to iFocus, and we love to listen to your lecture. But before that, I think Santosh has a small film on you to play. Dr. Santosh.
Yes.
Professor Harminder Singh Dua. Dr. Harminder Dua is the Chair and Professor of Ophthalmology at the Queen's Medical Centre, University of Nottingham since 1994. After obtaining Masters in Ophthalmology, Dr. Dua pursued Fellow of the Royal Colleges of Surgeons, Edinburgh, the Fellow of European Board of Ophthalmology, the Royal College of Ophthalmologists, the Royal College of Physicians, the College of Optometrists, an MD, and even a PhD. He was the 9th President of the Royal College of Ophthalmologists UK from 2011 to 2014 and has served as the Editor-in-Chief of the British Journal of Ophthalmology for more than 7 years. He is currently the Editor-in-Chief of the Journal of Cornea. He is also the Chairman of the Advisory Committee of the International Council of Ophthalmology, the President of the European Association for Vision and Eye Research Foundation, member of the Academia Ophthalmologica Internationalis and the American Ophthalmological Society. He is also the Master-elect of the Oxford Ophthalmological Congress and trustee of the Sussex Eye Foundation. His discovery of the Pre-Descemet layer, or more popular as the Dua's layer, in 2013 has enhanced the understanding of lamellar corneal surgery, posterior corneal pathology, and has led to the innovation of 3 novel surgical procedures. The layer has been recently endorsed by the Board of the American Association of Ocular Oncologists and Pathologists. He was listed by the magazine Ophthalmologist in the top 20 most influential individuals in ophthalmology worldwide. He was also one of the 5 ophthalmologists in the list of Britain's top doctors published by the Times magazine. He has successfully supervised 45 PhD and MD postgraduate students and has published over 350 papers and has an H index of 61. He has recently been elected as an honorary fellow of the Royal College of Ophthalmologists, the highest accolade conferred by the college. Amongst his over 100 awards and accolades are the Ophthalmology Society of South Africa Sam and Dora Cohen Gold Medal, the Rotary Foundation Global Alumni Service to Humanity Award, the Times Higher Education Award for Research Project of the Year, the Vice Chancellor's Medal, and very recently, the World Society of Pediatric Ophthalmology and Strabismus Gold Medal. Dr. Harminder Dua is a complete family man, blessed with a lovely wife and 3 beautiful children. He is a truly inspiring leader who has been endowed with honorary life memberships of 4 international academic societies, 1 eponymous lecture, the Dua Lecture, Birmingham, and a seminar room in the Nottingham Postgraduate Centre called the Dua Room have been named after him. Dr. Harminder Singh Dua, a leader with a greater vision, a professor who's truly inspiring, and a doctor powered by groundbreaking innovations. We are indeed honored to have him here today.
So, yeah, over to you, Professor Dua, please.
Thank you. I'm just trying to share my screen because that's open on my desktop.
Sunil, would you want to guide?
Can you click on the green button on 6 o'clock?
Yeah, I'm just yeah, I did that. You know, my it was all set, but for some reason now the PowerPoint is open, and I'm trying to see if I can find it in the. Sorry about this.
So when you click on the share screen, it will give you a window to choose what to share.
Yes, and share screen button. When I click on that, it's, let me. Sorry, just 1 second.
On the right hand side, bottom there is a blue button with on. Once the pop-up comes, just click on share.
Yeah.
Can you see my screen now?
Yes, sir.
Yeah.
Sorry about that glitch, because it was there and for a moment it disappeared.
No, it's perfect
Okay.
now.
Thank you so much. So, well, there were great introductions and a bit over the top, but thank you. And Mahipal, is one of the leading visionaries in India, as everybody knows, and I watched his Eye to Eye recently, and I was absolutely astounded by his achievements. So there are huge number of people with huge talent in India, and I'm proud to be one of them. And I'm grateful to him and Santosh for this kind invitation to be part of the iFocus series. Always a pleasure to interact with colleagues and to teach. So I'm going to look at the applied anatomy. The original title was of the cornea, but to keep it very much to the point and bring in a lot of new stuff, I thought I'll make it of the Pre-Descemet layer, relevance to corneal surgery and pathology. I have come up with this quote of my own, and I use this in most of my lectures. And at my age, I think many of you would start doing this. Is most of you would have heard some of this. Some of you would have heard most of this, but none of you would have heard all of this because there is something new in there. So if you look at the applied anatomy related to corneal transplantation, one would have to start with epithelial transplantation, Bowman's transplantation, anterior stromal, which is deep anterior lamellar transplantation, and endothelial transplantation. So I'm not going to cover the top two, which are in light blue, but the C and D. And then I'm going to talk specifically of something relatively new about the elastin content and distribution in the posterior part of the cornea relevant to endothelial keratoplasty, and then look at some pathological conditions where there have been fundamental and paradigm shifts in our understanding of these conditions from what we have thought them to be for hundreds of years. So a few of these initial videos you have all seen before. So that's a type 1 bubble in deep anterior lamellar keratoplasty. And the point I'm going to make here is that this was always described as a Descemet's bearing technique, but we now know that it's not, where you take off the top stroma, you dissect out the deep stroma by letting out the air, and then you cut out the 4 quadrants to expose the anterior surface of what we thought was Descemet's membrane, but we know is not. Now, if you look at the same operation in an eye bank human eye, what you will find is that when you inject air, see the circular movement of air, very important, that circular movement first, air leaking at the periphery, bubbles collecting in the center, and then a huge big bubble forming, which is now we know as the type 1 bubble. But notice that area there, that area where the bubble does not extend to. This is usually about 9 millimeter diameter that the bubble extends to, and we call this the type 1 bubble. So this is in an eye bank eye what you saw in the human eye previously. Now this is another kind of bubble. So you see this, the human eye, the bubble goes right to the periphery over there, right up to the periphery beyond your trifine edge, and doesn't have that white ring that we saw with the first bubble. So that is the extent of the bubble is quite large. And the same thing if we look at in an eye bank eye, what you see now, notice again that circular movement around the periphery. This bubble started at the periphery and then extended across the entire surface of the cornea. And air leaking. See again here, circular movement, the bubble starting at the periphery, another bubble starting here at the periphery, and the two meeting, and there is air leaking from around. And these are some examples of that. And we call this the type 2 bubble. Now, these features that I'm pointing to will all have a bearing on our understanding of the corneal anatomy and its relevance as we move forward. And this is one video from Dr. Katamish, and he's showing you the mixed bubble where he deflated the bubble, but there was still more air. Then he cut it and then deflated yet another bubble. And that we call a type 1 and a type 2 occurring together which is the mixed bubble. And here you can see examples of that. So there's a central type 1, and then there's a type 2. And we now know that when air is posterior to this pre-Descemet layer, you get a type 1. Sorry, when air is anterior to the pre-Descemet layer, and when it is posterior to the pre-Descemet layer, and between it and the Descemets, it becomes a type 2 bubble. And here again, the central is a type 1, and this crescent over here is a type 2, and we call these the mixed bubbles. And here's a very big example of that complete Descemet membrane bubble there, and the inside, you see this one is a type 1 of the pre-Descemet layer. So this is what we are seeing is happening at the back of the eye. But let's go back a step and see right from the moment the air leaves your needle tip, what happens. What you will see is different patterns. Sometimes you see this crack in the glass pattern. Sometimes you see a diffuse pattern. But with both of these patterns, air makes a straight line radially towards the periphery. You can see here, here, and here. And this one will also go right to the periphery. Sometimes it's a combination of the two, very diffuse with some radial spokes, as you see over here. So air is making its way from your needle tip preferentially towards the limbus. So what that's telling us is that although anterior-posterior movement does occur, the more compact the cornea, as you see over here in D, the more crack in glass type of appearance you get. But the coronal plane, coronal planes between the stromal lamellae are much less resistant to air travel, therefore less tightly bound to each other than the rest of the cornea. Now, what is actually happening, as you see over here, when we get this condition called infectious crystalline keratopathy, and you see this Christmas tree pattern and these radial spokes, very much like this kind of a crack in the glass appearance. Now, this is telling us that the microbes are also following the same path as the lamellae would determine for them. The compacter the lamellae, the more Christmas tree-like pattern. And if you soak a human eye bank cornea in tissue culture medium without dextran, it will swell. And then you inject organisms, you get clumps. You don't get the Christmas tree pattern. So the corneal microanatomy is determining the pathological appearance of the bacteria. But let's park that thought over here for now. Now look at that circular movement I mentioned. So the air will come straight from the tip radially back to the limbus, as you see here, and then it starts moving, and it moves clockwise and counterclockwise till it forms this complete circle. And that does this with unfailing regularity, even in the human live eye dart, not just in the eye bank eyes. Now, why is that so? Why is the air going? What is so special about that peripheral part of the cornea compared to the center? And if you look at it carefully, and this point will come up later as well, the width of this circumferential movement corresponds to the limit of the type 1 bubble. So this part will not form the bubble will be up to here. And that's very interesting because it's telling us a huge amount about the structure of the corneal stroma. So if you do this histology of that where the circular movement has completed, you can see that peripheral part near the limbus is swollen and it's aerated, there's emphysema, but the center is still compact and the periphery beyond that is still compact, as you can see over here. And here again, the same picture of another sample. So it's telling us that the corneal stroma at the periphery has got a different architecture to that in the center. It is easily separated and allows the air to move circumferentially. We know from studies now, from Keith Meek's work and other people's work and some of our own work, that there is a circular predisposition. It's like tangents of a circle of fibers at the periphery compared to the center, where you don't see that tangential orientation. It's only so it is that which is determining the circumferential spread, and it sort of gives credence to the belief and the observation that there is a circular structure of lamellae at the periphery compared to the center of the cornea. And then, of course, when you look at the progression of this bubble formation, the air collects as multiple little bubbles in the center, and then they coalesce, start of the type 1 bubble, and then the completion. And that part, you see, I showed you earlier, was the part where that circumferential bubble, the circumferential movement of air occurred. And that part is where this pre-Descemet layer is very firmly attached to the underlying stroma and does not lift off as a bubble. So again, we're learning a lot about the anatomy from the surgery, and of course, then the anatomy will inform the surgery. And again, the type 2 bubble is starting at the periphery over here, and yet another example after that circular motion is complete, and then moves across to complete the cover of the whole surface of the cornea. Here again, see the type 2 bubble is at the periphery in the mix. So 2 points. One, which I haven't yet said, which is both the Descemet's membrane and the pre-Descemet's layer are impervious to air. Air will fill the entire stroma. It will move anterior-posteriorly and circumferentially, but it will not go through the Descemet's membrane, and it will not go through the pre-Descemet's layer, right? That's important, and that at the periphery, you find that there is a different orientation to the rest of the cornea, and that the type 2 bubble almost always starts at the periphery. So these 2 points, impervious and the type 2 starts at the periphery. Now, how is it clinical relevant? And we've done some experiment. We have preliminary data. We all know that the cornea is prolate, and at the periphery, it flattens. Now, if you look at that width of that circumferential movement of air, that flattening corresponds to that area. So the corneal architecture, which makes it prolate, is the area where the air will only go circumferentially, and it's about 1.5 millimeters. So it corresponds to that thickness. And what it means is that the foundation of the cornea is that part of the periphery. The central cornea is very, very unstable, but it has to spring back to its normal shape every time, with each blink, with each heartbeat, with each respiration, with each forced blink, because if it doesn't come back to its normal shape, you won't get the proper focus of light. And you can hardly tell that it's distorted because the focus is always maintained so accurately. It is that rim that is allowing it to do that, that foundation provided by these circular fibers, where it becomes flatter and is thicker and is more compact in arrangement, and where you also have that circular orientation of bundle. So that is a clinical relevance of that part of the cornea. Now look at the OCT anatomy of these bubbles, and we'll talk a bit about OCT as well. So this is a type 1 bubble. You see one line. There's another type 2 bubble. They look very similar here because this is Visante OCT, and the resolution is not very hard, and this is a mixed bubble. So you've got a large type 2, which is the Descemet's, and the type 1, which is the pre-Descemet's layer. So remember, OCT corresponds to histology, but OCT is not histology. OCT is telling us delineation of points of different refractive index. That's all. It is not telling us the histology, although we often try to interpret in that sense. Wherever the refractive index changes, OCT changes. Look here, that's just a reflection. So here you can see this is a type 2 bubble. So there's Descemet's membrane. You might see 2 lines right over there, very close to each other, these 2 parallel lines. This one is a type 1 bubble, and this is the pre-Descemet's layer, and that's the Descemet's membrane. Here again, the type 1 bubble, pre-Descemet's layer, Descemet's membrane. These are slightly higher resolution OCTs, and over here you can see it's a type 1 from which the Descemet's membrane has been peeled off. So you're not seeing that other line. The point I'm going to make here is that this double contour line can be also seen with a greater space in the type 1 bubble, but the Descemet's membrane will always give you this double contour line on its own when you do ultra high resolution or high resolution OCT. And as you see over here, this is a normal cornea. You can see even the tear film is there on the top. Then you can see the epithelium, the Bowman's, the stroma. And look at the Descemet's membrane here. It's giving you that double contour line, the double contour line of the Descemet's membrane running parallel to each other. And that, in this case, of course, the pre-Descemet's layer is also there. But if you had only the Descemet's membrane, you would still get that 2 contour lines. One is differential refractive index between stroma and anterior surface of Descemet's membrane, and the other is between Descemet's membrane, endothelium, and the posterior liquid, the aqueous behind it. So those two changes in refractive index are giving you those two lines. Now you can do ultra high resolution OCT in the human eye, and this is the work by Bezever, who has shown exactly what we had said in our first paper. Beyond the last row of keratocytes, this layer here, this bit you see is the Pre-Descemet layer. This was the first in vivo demonstration of the Pre-Descemet layer with ultra high resolution OCT at the time when people were saying, oh, we can't see it in OCT, therefore it's not there. And exactly correlates with histology as we published. You can see the last row of keratocytes, and then the Pre-Descemet layer, and then you have the descemet and the endothelium. And the double contour of the descemet, remember, these two lines are telling you the anterior surface and posterior surface of descemet membrane. Now, looking further at the anatomy of these bubbles, you can peel off the entire descemet membrane from the layer underneath, the Pre-Descemet layer, without it bursting. So you can see that that layer is impervious to air. And when you peel off the descemet membrane from a type 2 bubble, or from a type 1 bubble, or from a mixed bubble, it is always the same on histology. People used to say that it is a split between banded and non-banded zones of the descemet membrane that is giving us a mixed bubble. That does not happen. It is not that. We now know that it is actually a type 1 and a type 2 mixed. And you can see that the histology is always the same, the endothelial cells, the non-banded zone and the banded zone of the descemet membrane. Now this is a very important little video. So there's a type 2 bubble. So we peel off the type 2 bubble, it immediately collapses. You can take the entire descemet membrane off. Now when you take this descemet membrane off, if there is a layer underneath it, which is the Pre-Descemet layer, then you should be able to inject air in the stroma and create like a type 1 bubble. And that's exactly what this video shows. And others have gone in. You can see, you can still create that, right? So that is the Pre-Descemet layer bubble from which the descemet membrane has been removed. So it is telling us that the descemet membrane has no role in the creation of this bubble, but it is there independently because of that layer that is lying. And again, notice that flat area there, we talked about that circumferential movement of the air repeatedly, you will see every time. And this is then looking at a little bit of ultrastructural anatomy on scanning EM. You can see that's the role of, that's the descemet membrane, and that's the Pre-Descemet layer over there, which you're seeing at the back of it from the descemet membrane and the endothelial cells here. This is the posterior surface of the cornea, multiple holes, and then that is what I want to draw your attention to, is the Pre-Descemet layer. And towards the periphery, you will see strands extending from the deep stroma to the Pre-Descemet layer. You see more of these closer to the periphery. And here again, you can see the descemet membrane, the Pre-Descemet layer on top, and you can see the air in between. And on transmission histology, you can see on electron microscopy and light microscopy, these are the strands that are peeling off. That keratocyte will come off, and that layer that is left behind, the Pre-Descemet layer, has no keratocytes. Here again is a high power, so the endothelial cells, descemet membrane, and that's your Pre-Descemet layer opposed to the descemet membrane. Another picture is showing something similar. Now, what is also important is that this layer is acellular. So in histology sections, you're looking at a very teeny bit of it. How about whole mount sections? You can see this, the Pre-Descemet layer in a whole mount. Some of the strands are there. You only see a keratocyte in one of the strands that it was peeling off, but the actual layer has no nuclei over there. And here's a bit of descemet membrane, a lot of endothelial cell nuclei, but you can see there is no nucleus. So it's like a positive control of the stain. Nuclei was staining, but because there were none in the Pre-Descemet layer, they didn't stain. So another feature of this layer, there's paucicellular or acellular layer. And this is scanning and transmission electron microscope. This is a bit low power, but you can see over here, the descemet has been cut. That is the zone where the circular movements occur, and that corresponds to the flat part of the cornea where this layer is firmly attached. Now, why is this a separate layer? Why not something, why is it so unique? Why just not another random separation of the stroma, as it was called, residual stroma? So here's this experiment, which is quite an interesting one. So you take an eye bank eye, you take away the complete Descemet's membrane from it, you flip it upside down with the posterior surface anterior, and then you mount it on an artificial anterior chamber. You fill it with BSS to make it taut, and you do PTK from up to 20 microns or slightly less. Now you've got rid of that layer. If you inject air, you should make another bubble, but that doesn't ever happen. What happens is that from multiple leaking points, air is escaping, and you can never create another bubble once you've got rid of this layer, because there is only one layer that you have. And the same picture here to show histology that we had ablated it, but it's not just by air. You can physically, mechanically separate this layer by just teasing it off the back surface of the cornea. And this is from a workshop we were doing on DMEC. So you can see that once you've taken the Descemet's away, you can actually peel this layer off. And here it shows you the cornea from which it has been peeled off. The Descemet's membrane is scrolling tightly like that, but the Pre-Descemet's layer is not scrolling as much, and it doesn't actually scroll as much. And again, there's an interesting reason why it doesn't, and we'll come back to that very soon. Now, this is very important. Many of you may not know this, but it's quite an interesting clinical fact which one has to be aware of. Many people do visco-bubbles for DALK. Now, if you inject viscoelastic, you can get a successful DALK. But here you get the fourth type of bubble. Now, if your visco needle is injected closer to the surface where the stroma is very compact, you get diffuse spread of viscoelastic, and that OCT shows you the needle point very near the surface. You don't get a bubble. If you go to the mid-stroma and you put your viscoelastic, you get an intrastromal big bubble, IBB. Look at the amount of tissue, amount of variable thickness of posterior stroma that has been torn apart as the viscoelastic has built up pressure inside the stroma and just stretched it apart till it tears. Sometimes it's just a diffuse spread, as you see here, or you get that intrastromal big bubble. Now, many people who do visco DALK do not realize, because to look at clinically in the operating table in the patient, it looks exactly like a type 1 bubble. But the difference is that you're leaving behind so much stroma, which you don't do when you use air. And there are many examples. Now, if your needle is really deep, then you do get a type 1 bubble, and you can get a very nice type 1 bubble like this. Over here you see on OCT when it's deep enough. But even with deep ones, sometimes you can get an intrastromal big bubble, as you see. And we've done this in many eye bank eyes. And if you go back and look at people who do big bubble DALK with a viscoelastic and look at the OCT, often what they've left behind is not the PDL. It's not the Pre-Descemet's layer. It is more stroma, as you see here. And then you can see over here 3 different examples of the amount of stroma you might leave behind in DALK. And from the surface, it will look exactly like a type 1 bubble, but it's not. So important to understand anatomically where you are in your surgery. And if you have OCT, it's a very good way to tell you how much stroma you have left behind. Then that brings me to this very interesting and intriguing second part, which is the Elastin, Keith Meek's group again, and they've worked a lot on the corneal architecture and stroma. And this is a poster where they showed, and this is what made them acknowledge their own research, that this layer is there. Because what they've said is that the Pre-Descemet's layer has got more elastin. It's about the 8 microns of 8 to 10 microns of most posterior stroma, more elastin fibers, the yellow fibers, than the rest of the cornea. But they use scanning on-face electron microscopy in a serial manner to show that. And this is the area they were looking at, which is exactly where the Pre-Descemet's layer is. So what we then looked at this in a little more detail. And this is where you can see anatomy comes into synthesis with physiology and with function and with surgery. So we know that the Descemet's membrane scrolls a lot. Why does the Descemet membrane scroll like that all the time? And the answer given was because of elastin in the Descemet's membrane and because of the swollen endothelial cells, because the Descemet's membrane always scrolls with the endothelial cells outside. But the PDEC tissue scrolls less. This is DMEC tissue, this is PDEC tissue, but it scrolls. But very carefully, if you separate from this tissue after taking this picture, the Pre-Descemet layer from the Descemet's membrane, you'll find the Pre-Descemet layer scrolls the least, right? So that is the physiological behavior of these three layers singly or together. Now, if it is elastin, that's fine, that's why it will roll, but why always in one direction? It doesn't give the answer. And if it is swollen endothelial cells, yes, if they're swelling and they're going to push this, they're going to push it to roll like that, so the cells will be outside. So we measured the amount of elastin in the Pre-Descemet layer, in the Descemet's membrane, central cornea, peripheral cornea, trabecular meshwork, sclera. We found that the highest content was in the Pre-Descemet layer, and there was no difference between that and the trabecular meshwork, but it's significantly more than in the Descemet's membrane. So that was the first observation. Yes, there is elastin, and this was biochemical estimation of elastin. But look at these pictures. Now, when you do immunohistology, that's the Pre-Descemet layer, the entire thickness of the Pre-Descemet layer has got elastin. So when you do DALK, you can see how much that bubble goes into the eye, and then when you release the air, it comes back. So you stretched the Pre-Descemet layer and Descemet's membrane, but it always comes back to its normal shape. So this Pre-Descemet layer is like a rubber band. You pull a rubber band and you leave it, it'll come back. The Descemet's membrane, this is a new bit of the anatomy, has got elastin only as a dense band on the anterior surface. The rest of the Descemet's membrane has very little elastin. Now, and this is a PDEC tissue where you've got the Pre-Descemet layer over there, the band of elastin on the Descemet's membrane. And just to show you how, if you take away half the PDL from the PDEC tissue, so the Descemet's membrane has that dense band and the PDL has all across. If you take a whole cornea and you make a section, again, you see the same, the Descemet's membrane band, an interfacial matrix, which is a dark line, and then that dense staining of the entire thickness of the Pre-Descemet layer in the posterior cornea. So here is the explanation. If you take this rubber band and you stretch it, and it will come back. But if you stretch it and you stick it to a piece of paper, now it will come back with the paper on its outside. So when this band is going to curl, when you detach it from its attachments at the periphery, it will curl inwards with the endothelial cells outside. So that is the explanation why it curls always with the endothelial cells outside, which is very important in orientation in PDEC and DMEC operation. But that's not enough evidence. Look at this now. If you take a Descemet's membrane that has been scrolled up like this, and you put a drop of elastase enzyme and leave it in front of your eyes, given time, it will start to unscroll and become completely flat, as you see over here. You don't have to touch it. The elastin is degraded. And if you do a section of this cornea, a histological section, you can see the elastin band is completely degraded, as against the control where it is completely preserved and it has not unscrolled as you see over here. So elastase digestion and degradation makes it unfold. So the exciting part here is we're now doing experiments to see what temperature, what concentration, what duration can we soak DMEC tissue in elastase without damaging the endothelial cell, just to make it weak temporarily so that we can unfold it in the eye and it recovers. But that's the challenge, but you can see how anatomy, physiology will now inform surgery going forward for new innovations. But what about these swollen endothelial cells? So take a look here. You read a lot in literature, but if there's no evidence, don't believe it. So here is an endothelial cell layer on the Descemet. So with dispase, you can gently take away all the endothelial cells, and then you leave it, it will still curl exactly like it does without the endothelial cells as it does with. So the endothelial cells actually have no role in making it curl at all. It curls because of this elastin band over there, and the evidence is over here. So that's the evidence. There's no evidence that this plays a role. It might be playing a slight role, but not a significant role. Now, God didn't make this complete distribution so that we could do DMEC. So what is the physiological role of this distribution of elastin in the Descemet's membrane? And there has to be an explanation. So this is it, I think. So this Descemet's membrane has to be constantly opposed to the back of the cornea so that it can keep it dehydrated through the endothelial cells. And how does it attach? There is no physical attachment. There's just interfacial matrix. Yet it has to be constantly opposed to the back. And if it is trying to curl in this direction, trying to curl inwards, it will force it to be against this. So the arrows are telling you the direction in which this tissue is trying to curl. And that will make it always opposed to the back of the cornea, thereby, without any physical connections, it is allowing the Descemet's membrane to stay where it should. And despite all the movements of the cornea, that shearing force will not be transmitted to the Descemet. It won't rip or fold because there is that buffer in between, but yet it will be firmly opposed to the back of the cornea because of the elastin. So that, I think, is the physiological role of that distribution of elastin. Now, coming to how anatomy informs surgery, by looking at the two, you can tell this is type 1 bubble because it has this rough surface due to the anterior stromal fibers that you see on the Pre-Descemet layer compared to the Descemet, which is completely homogeneous and monotonous, and there is no fiber attachment. So you can immediately tell which type of bubble you've got. It's very important because this type of bubble is very vulnerable to lots of problems, as you'll see in a second. Now, if you get a mixed bubble, so again, how anatomy informs surgery, and the bubble, this type 2 bubble is right at the periphery, what you don't want to do is a paracentesis and burst it. If you've got a partial type 2 here in this mixed bubble, then you won't come from here to do your paracentesis, but you can come from here. So immediately you see, you understand the anatomy, you know how to make your surgery safer. But watch this video, don't blink. Right? As I nip that edge there, the whole Descemet bursts. Now, this is before we knew about type 1 and type 2 bubbles, and it's 360-degree rupture of the Descemet membrane, all gone, right? You can avoid this. What you have to do is repeated paracentesis to keep your Descemet membrane flaccid. First thing, know that you've got a type 2 bubble. Know it's only Descemet membrane. You know that it is very vulnerable. Second, avoid that by too much manipulation, and you release aqueous, not once, but every 1 minute, every 2 minutes. Keep it as flaccid as you can while you're cutting the edge, trimming the edge, and while you're doing your suturing, so that you don't burst it. Otherwise, it's like a tense balloon. You touch it with the needle, it bursts on you. Look at this here now, right? Kana Ramesh sent this video to me. He just completed the DALK, he put the tissue on the top and moved the eye, and the whole thing burst. So don't manipulate the eye too much if you've got a type 2 bubble. Now that we know, we can safely do a DALK in all these situations of type 2 bubbles and get a good result. But we never understood why some of them burst and some didn't burst, but there's your reason. And this is a type 1 bubble with a tear. I'm very robust. The tear doesn't extend, the tear doesn't go across, it doesn't burst. And you can see I'll put my probe in that tear over there. And with that large tear, you can complete the operation successfully. You don't have to abandon or convert into a PK. And the next day you see this patient, you will see there's that line to show you that there was a tear, which is now caused laxity and a wrinkle in the Pre-Descemet layer, but you got a successful outcome. So again, anatomy informing surgery. This is from Vinay Pillai in Trivandrum, very interesting case. He'd done a successful DALK, but the cornea didn't clear. There was no aqueous leak, and there wouldn't be because there was a nice mixed bubble, and the Pre-Descemet layer was intact, so there's no leak, but the cornea didn't clear because OCT showed that the Descemet had torn and scrolled up. And that torn Descemet would not allow this to heal for quite a while. And then they did a PK, and the histology showed that there was a Pre-Descemet layer there and the Descemet membrane separate, and it had scrolled. So once again, the anatomy is now giving us understanding of what's happening in our surgery and why things happen, which we didn't know before. Now, if your bubble doesn't go all the way to the periphery, you encounter these strands. Remember, I mentioned these strands, which you have to physically separate. and sometimes they're strong, particularly to the periphery. You have to cut them so that you can separate the stroma all the way to your refined mark. So you just exploiting that plane physically where the air did not reach. Now, this is again Rishi Swaroop's video, excellent. They tried a visco-bubble to create, tried viscoelastic to create a bubble in DALK. It didn't work. Physically, you can peel off the cornea. Look at the force they're putting, and you get a beautiful plane of cleavage between the posterior cornea and the pre-Descemet layer. If you do that much force on the Descemet membrane, it's going to burst on you. So knowledge of that existence of that cleavage plane is very important, because you will not always get a good bubble of the right size, and you have to resort to other maneuvers, and this is one of them. Now look at this video again, showing you the same, how you can physically exploit that cleavage plane. So here we're going to inject air. As soon as you inject air in the patient, it goes in the AC. So we perforate it all the way through. But don't give up. Go another side. Okay. Now you got a small bubble, that small area. So you complete your DALK just as you would. If you put viscoelastic, it slows the rate of escape of the air. But look, all the air which was inside the anterior chamber and in that small bubble has come out. Now you go with a spatula and you can completely separate that layer, the pre-Descemet layer underneath, from the rest. And you cut off the quadrants. And it looks exactly like a type 1 bubble with air. You put your new cornea and you succeeded. If you try to do a bubble with a perf in the Descemet, you will never get, because air will always go in the eye. But even a small bubble that you get to it and you can use it to physically cleave. So again, the anatomy informs surgery. Now you know there's a plane of cleavage and you can exploit it to your advantage. Now then, moving on. So this is another feature about the anatomy. At what pressure does this burst? Because you want to push it more to the periphery. You keep pumping air. Look at the air escaping. You keep pumping air and the bubble bursts on you. Now we measure that to be around 700 millimeters of mercury. You take the Descemet membrane off, and now you can see what this layer actually looks like, in the living state, in the eye bank eye. It's very resilient. And when you pull it, you can see the stria going all the way to the periphery. So although the bubble stops there, the layer doesn't stop. The layer goes all the way. It's translucent, it's strong, and it's elastic. So that is a part of the anatomy or anatomical knowledge. But how do you adapt that to surgery? And this is from Dr. Zaidi. He was doing a DALK, got a type 1 bubble, but there was a cataract underneath. So he did the whole cataract operation underneath a type 1 bubble. And in one case, and this is the patient, there was a PC tear, so he did a vitrectomy as well, and then he put a sulcus implant. You can do a complete cataract operation under a type 1 bubble under the pre-Descemet layer, but don't ever try it with a type 2 bubble, because the moment you inject the viscoelastic, it's going to rupture. So it's possible. So you can imagine a patient with such a dense cataract and a dense scar, you do a DALK and the patient gets up still not seeing because of the cataract. He's not going to be happy. But you can combine the two procedures together. Of course, biometry is an issue. And these are some examples of that. Then coming to the final operative kind of intervention is this, where you can create a type 1 bubble, you can take the air out, you can refine it, and use that composite of the pre-Descemet layer, Descemet membrane, and endothelium to do endothelial keratoplasty. So this is what we proposed in our very first paper in ophthalmology in 2013. And then Agarwal and I developed this into an actual procedure, and we published a paper together on PDEC. So you can see how that, and it scrolls much less, as I've already shown you, than DMEC, and therefore easier to unroll in the eye. And the easier it is to unscroll in the eye, the less endothelial cell loss you get. Now, coming back to anatomy. Now, I told you the pre-Descemet layer is impervious to air. And the question you'll be asking is, then how does air get through it to cause a type 2 bubble? How does it get to the plane between pre-Descemet layer and the Descemets? So the answer lies in the fact, which I've also mentioned several times, is that the type 2 bubble always starts at the periphery. So we mark the spot where a type 2 bubble starts, and we made the type 2 bubble, and you peel off the Descemet's membrane, which is here, and what you see underneath is this. And this is another feature of the microanatomy of the cornea, which was not known, that all along the periphery of the cornea, where the pre-Descemet's layer actually starts to open out to become the collagen core of the trabecular meshwork, you have about 15 to 17 clusters or individual holes all along the periphery. The mean diameter is 20 microns, and you can see these holes over here. Air escapes from this and accesses the plane of cleavage between Descemet's membrane and pre-Descemet's layer, which is the plane of the type 2 bubble. So if you imagine this is a very high power electron scanning micrograph of the pre-Descemet's layer here, which is becoming the trabecular meshwork. See, it becomes a trabecular meshwork. These are continuous, they're one structure. And you have these holes, right? So if the Descemet is attached here and you inject air, air escapes, it'll go into the anterior chamber, and we see that very often in DALK. But if the Descemet is attached here and air leaks out from those holes, it's going to start separating the Descemets at the periphery to give you a type 2 bubble. So that anatomy explains now to us what's happening in our surgery, makes you more confident doing what you're doing. But it also informs surgery in a different way. So we said, look, for doing PDEC, you don't want a type 2 bubble. So how do you stop a type 2 bubble from forming? Well, let's just stop those holes. So if you block all those holes with a clamp, there's no way air will escape, and you can get always a type 1 bubble, which is what you want for a PDEC. So we designed this clamp with a side hole to inject the air. And here's an example of that. You can see in an eye bank eye, and this mark tells you where the hole is. Centration is important. Clamp it down, because that's the part you're not going to use. The bubble doesn't go in that flat area, if you remember. And you inject the air. Now, two advantages. You see that no air escapes, so very slow injection will build the intra-tissue pressure to the level you want it to create consistently a type 1 bubble, right? Otherwise, you have to, if air is escaping, you have to push the plunger hard to overcome the pressure lost by the escape of air, and sometimes you do it too hard, this thing bursts on you. This way, it doesn't burst, and you can also then insert the needle tip into the bubble, you put a little more air, and you will get a slight increase in the size of the bubble. You can see the periphery is compressed such that there's absolutely no aeration of the stroma there, no air escaped. You got a nice type 1 bubble. The dotted line tells you the full extent after it has, which it was before it collapsed. And that's the operation of PDEC, which everybody is familiar with now. You can create the type 1 bubble, you can cut it out, refine it out, load it, inject it in the eye, put your, just like a DMEC, and the outcome is also exactly like a DMEC. But the big advantage is you can use eyes of any age, because with DMEC, you can't go below 50, or the lower you go, the more it rips and more difficult to separate it. And if you go with young eyes, and this Agarwal has shown, if you go with eyes 1, 2, 4 years old, and you do PDEX, you get much clarity and much better outcomes than if you use an older age cornea, even if the edema had persisted for many years. And then again, based on the same anatomical knowledge, somebody came up with a poor man's way of avoiding a type 2 bubble. And this is again a paper which Nicholas Pereira and myself and others have sent to the BJ's, come back for a slight revision, and we've resubmitted it. They said, you know, this air at the periphery that is escaping, if you score the Descemet membrane 360 degrees and you just tear it over there, then you inject the air, any air escaping from here is going to escape out and not lift the Descemets, because it is not collecting on the Descemets, and you can keep injecting until you get a type 1 bubble. So you don't need the clamp. And the only advantage is, a disadvantage I would say rather, is that you don't know how much force to inject, and you can overdo it and rupture the bubble, because you have, like I said, overcome the pressure loss from the bubbles escaping to create enough intra-tissue pressure to create the type 1 bubble. So that is the disadvantage. Otherwise, you can do this way, completely avoid a type 2 bubble. But if you do get a type 2 bubble and you're okay with doing DMEC, then you use it for DMEC. Now coming to the pathology, which we'll look at and then finish off, is that Descemet's membrane detachment. We've been talking about that for years and years, but this is something we recently published in the AGO, is that it is exactly like the bubbles. You can get a Descemet's membrane detachment with PDL and Descemet's membrane. It is like the chord of a circle, a straight line, and it is much more taut. It can be a type 2 bubble, which is like Descemet's membrane detachment only, and you see that double contour line I was telling you about. Or it can be like a mixed bubble. So you've got both of them have detached and also separated from each other. So Descemet's membrane detachment is not just this, which is what we thought it was, what we've been taught and what we believe. It is this and this. And these together are more often than this alone. And you will find that now you go back and look with OCT at all your Descemet's membrane detachments, they're of these different types. And sometimes it can be the type 2 detachment can be torn, and then it curls up like that. Now, if you look over here, we've got examples with histopathology to prove that the pre-Descemet's layer is there anterior to the Descemet's membrane in a type 1 Descemet's membrane detachment. This is not with air injection or anything. It's not post-surgery. It is just spontaneously following cataract surgery. This is following a cornea transplant. Give it time, and this membrane, the pre-Descemet's layer, will get populated by keratocytes, and it will become more scarred, and it becomes like a tarpaulin, and you can't, a trampoline, you can't put it back. You might have to do a descemetectomy if the endothelial cells are still there. So straight away, we've learned if you have a type 1 detachment of some standing, of some duration, then it's not, the prognosis is not going to be good if you're trying to put it back because of the scarring that occurs in the PDL due to population from cells coming from around. But if you have a type 2 detachments, it will be easier to put back. And here you can see an example of a mixed detachment. You can see over here, the Descemet's part. You see 2 lines here. Again, a lot of people contributed, and I think this was Sharon D'Souza's patient here. And then here you can see it looks like a type 1 over here. And then here the 2 are separating as in the mixed. And then you can see here the Descemet's has separated and torn and curled, but the pre-Descemet's layer is intact. And if you see a strand extending from the posterior cornea to your Descemet's, be absolutely sure, 100%, that this is pre-Descemet's layer. It's a type 1 detachment because you don't get any strands between the pre-Descemet's layer and the Descemet's membrane. And then again, from Sangeeta Wagh, I got this amazing case of Morin's ulcer where they had Descemet's membrane detached. See that straight, taut chord of a circle appearance. And then they waited for a while, it cleared, the cornea cleared, they treated this with immunosuppression. But the interesting thing they did was they let the Descemet's membrane detachment be, this was the type 1 detachments. There must have been a tear or a hole somewhere from which the endothelial cells repopulated the back of the cornea cleared, even some endothelial cells you can see on specular, and they did a cataract keeping that in place. They were prepared to do a DSEC, but they managed to do a cataract, the cornea stayed clear. Now this patient has this kind of a cornea with a cataract operation, and you didn't have to go back and do anything else. So these things are possible, and now we understand what's happening because of our knowledge of the anatomy. And not only the plane of cleavage is being exploited by us, but even by fungi. And you can see in this picture, these pictures by Liu, they show that in keratitis profunda and fungal keratitis, the fungi reach the cleavage plane anterior to the pre-Descemet's layer, and then they spread along that. And then my own fellow, Kostas from Greece, who's currently with me, one of our patients, he did these OCTs and shows beautifully how you get what looks like a type 1 detachment, but that's the plane in which the fungi are growing. And this you see only in deep fungal infections, as this is the patient over here. What about acute hydrops? Now, I know how long as any one of you can remember, you've been told acute hydrops and keratoconus is due to rupture in the Descemet's membrane. And we all believe that. But after discovering this layer and doing some OCTs in our very first paper, again, all this information is there. We said that acute hydrops is due to rupture in the Descemet's membrane and the pre-Descemet's layer. And we have one example over here, and you can do an OCT and you can see the Descemet's membrane, pre-Descemet's layer, both are torn, and there's lots of fluid in the cornea. And this you will see again and again. Here, acute hydrops, that rip is in the pre-Descemet's layer and Descemet's membrane, not Descemet's membrane alone. And you can see here, they're both torn, there's an excavation, and there's fluid in the stroma. Now, at that time, nobody commented on it, and it was just left as a statement. Here again, you can see in pellucid, we had acute hydrops, but what you see here is that strand. When you see that strand, you know that the pre-Descemet layer, and here you can see the separation is quite wide. These are wide. So these are not the two layers of the OCT layers of the Descemet membrane alone, it's these two layers. But that strand clinches it, and in acute pellucid also we had hydrops. It's because of that. And on that basis, Marc Muren, professor in France, said, if DUA is correct, then we should be able to approximate the pre-Descemet layer, let the Descemet membrane endothelial cells grow on it later, because that will provide the basis for the cells to grow, and we can resolve acute hydrops. And that's what he did with the mattress sutures. And then he said, his comments are there for you to read, that the fact that the pre-Descemet sutures can also be affected, explain the existence of the DUA's layer, and so forth. And it got a very rapid reduction in hydrops. But this was the most telling paper very recently by Mellis. His group acknowledged not only that this layer exists, but also, because Mellis is one of the stalwarts and the most leading figures in endothelial keratoplasty, the innovator of many, many different things. So a very respected person who I hold in very high regard. He started this Bowman's membrane transplant. So when they were doing Bowman's membrane transplant in keratoconus, and when they had Descemet membrane detachment and tear, they never got acute hydrops. But when they were doing Bowman membrane transplant and inadvertently they perforated the stroma downwards, rupturing pre-Descemet layer and Descemet membrane, they got hydrops all the time. So they said that this is due to a rip in the pre-Descemet layer and Descemet membrane, as we had said, and published in 2 papers prior to this. Now, there's still a catch, and some of you may be thinking about this, is that if you do this in a normal eye, then, and what we came and did, so if you take a normal eye and you put a cut posteriorly in the Descemet and pre-Descemet layer, put it on an artificial anterior chamber, and you pump up the pressure, you never get acute hydrops. This is an eye bank eye. So what's different? I think what's different is that this rupture has to occur in the context of the abnormal collagen and glycosaminoglycans of a keratoconus cornea. So we wrote a letter in response to his paper, which paper was very supportive of what we had said anyway, and it was the first actual clinical evidence that that was the case. But we wrote this letter saying that we have to add this to it because it doesn't happen in the normal eye. And then they wrote back actually completely agreeing, and they say, we thoroughly agree with the primary point of the letter, namely that this is to be a deoltostromas. As we learn more about this collagen structures, hope that more and better treatment will appear. And then and of course, they were a bit complimentary in their comments. So you can see how everybody is now coming around to understanding that this layer is there and how it is informing not only surgery, but also pathology. And people from all over the world have been sending things. But this patient had an injury with colloidal silver, and they had to do a graft. So they took the cornea off. And what he said is, he's not a cornea surgeon, but he picked up very astute in his observation. The lady, Natalia, what she said was that, I noticed that the pre-Descemet layer is not staining. Everything else is staining brown with the silver that caused the injury. The pre-Descemet layer didn't stain. And then there's the high power. So that layer is something different, something unique about it. But most of the staining is around the keratocyte areas. Because there are no keratocytes over there, that's why maybe it's being protected. But there you should see that even in this pathology, it stands out that there is a separate thing over there which is behaving differently. And of course, descemetocele, most of the descemetocele have a pre-Descemet layer. Some have more stroma than just the pre-Descemet layer. Some have the pre-Descemet layer and some have only Descemet membrane. So like acute hydrops, like Descemet detachments, even descemetocele are not what we thought they were all these years. Many of them will have a pre-Descemet layer. And when that is lysed, then you get perforation. And I'm not going to tell you this other than the fact that we know that the trabecular meshwork is a continuation of the pre-Descemet layer, and that's something we will see. But there is more to it. And this is, I must acknowledge, Ghorpade, who and his colleague Moreker, who showed that in deep sclerectomy, if you excise the pre-Descemet layer and leave only the Descemet membrane behind, then you get a better outcome than if you leave the pre-Descemet layer there. So even for deep sclerectomy in glaucoma, this will be important. And we've got 2 grants now to look at the role of the pre-Descemet layer in glaucoma and in its relationship to the trabecular meshwork and in the maintenance of eye pressure and in posterior corneal biomechanics. So a lot more is to come. And my thought I want to leave you with is the eye cannot see what the mind doesn't know. And this is a famous quotation we used to be told when we were medical students. But when you look beyond what the eye can see, you will discover a whole new world out there waiting for you. And to finish off, it's even in animals, comparative anatomy. These are Staffordshire dogs. They consistently produce a type 1 bubble. The eyes are bigger than ours, huge type 1 bubbles seen in dog eyes, same pre-Descemet layer, and horse eyes, like a tennis ball. They behave very differently, but here again, you've got a mixed bubble. See, the Descemet membrane on the top and the pre-Descemet layer bubble, but there are other features of a horse eye which are very different. So very exciting times ahead as we learn more about these now in the animal world and not just in the human eyes. So just want to acknowledge 2 members of the team, and there were many others along the way. And I really thank you all for giving me the opportunity to speak and to share these findings, some recent findings with all of you. Thank you.
Thank you very much, Dr. Dua, for the great insight that you have provided. We have corneal surgeons who are going to be the panelists, and Dr. Varun is there, Dr. Mukesh is there, we have Dr. Lakshay Dudeja, Dr. Tulika, Dr. Pratik, Vikas, Abhishek. Panelist, the session is open for questions, discussions, and any comments that you have on the excellent talk that Dr. Dua gave. It's always fascinating to hear him and the great number of videos, the great number of ways in which he actually brings out the intricacies of the various layers of the cornea. I think it's really a treat to listen to him always. So over to you, Dr. Mukesh, Lakshay, anybody, the panelists, any comments? Dr. Mukesh? Dr. Mukesh is our medical director for our Jaipur branch, and he's also from RP Center. And he did a lot of work, actually established the eye bank at SMS Medical College, Jaipur. Mukesh.
Hi, hello.
As usual, it's really fascinating and eye-opener talk. Like every time we listen to you, Dr. Dua, we always get to know about different things and new things. So it's really wonderful. And we all now are acknowledging the fact that pre-Descemet membrane really exists, and we ourselves are also doing the surgery PDAC. One question which comes to my mind is that is there a difference in pattern of rupture of pre-Descemet layer and Descemet layer? Like clinically, when we see Descemet rupture, say in congenital glaucomas, we tend to see horizontal lines, half stria, which are concentric to the limbus or which are. So do we have that kind of pattern of rupture in pre-Descemet layer also, or something different from this?
It's a question that has crossed our mind, and many students ask, is the rupture, let's say in acute hydrops, is it always vertical or is it horizontal? And although we have found that it is often oriented vertically, either this way, but it can also be horizontal. So there isn't any hard and fast. What determines that would be, if you remember in keratoconus, what is happening is a slow, continuous process, is that the pre-Descemet layer is becoming stretched and thin, and the elastin is being degraded. I had it in my slide, but I didn't mention it, that it is believed now, and we've got some studies going, that the posterior keratoconus is because of degradation of elastin in the pre-Descemet layer. So when it is stretched and it loses its elasticity, then where it has lost its more, it'll rip. And that shape of the tear might not be consistent. And the same when you have a a baby born with forceps delivery and the elastic eyes, and too much pressure is put, and they usually grab the head in a particular way, and if too much pressure, the eye is forced to span in one direction, you get a rip like that. So the direction of the tear, I don't think I can give you a reasonable answer for, but I can tell you that when the Descemet tears, you injure a small area and you get a big rip. That's not what happens with the PDL. In fact, in the Pre-Descemet layer, if you got a mixed bubble, you can just put a needle over the bubble between it and the Descemet membrane to release the air. But you can't put a needle in the Descemet membrane because it'll rip much bigger. And also the Descemet membrane will curl a lot. This will not curl that much. So those differences are clear cut. I used to give an example. I always used to carry balloons in my bag. You take a balloon, and I always have pins on my head anyway. So you take a balloon and you inflate it, and you take a pin and you touch it, nothing happens. But if you inflate it really tight and you touch it, you try that at home, most of the time the balloon will burst, the top will fall off, and you're left holding the stump. Because that's how the Descemet bursts in that example I showed you. It just comes off. And that is the difference, because the denseness of that pressure of the eye, the intraocular pressure held by 20 microns of Descemet, that causes it to stretch like a stretched balloon. You touch it with the pin or any instrument, it'll burst. So those are very important differences in how the two tear.
Yes, sir. I think the same thing we have realized in dealing with post-cataract surgery Descemet detachments. And like actually they were pre-Descemet detachment, and like we were not able to settle them by injecting air and everything. But finally what we did was multiple stromal punctures, and then followed by the air injection, and then they got settled up. So the fluid which was there above the pre-Descemet layer, it got to be released for settling these kind of detachments. So I think this once again stress out the point that the space exists there above the pre-Descemet membrane, and it needs to be handled well in these cases.
Yeah, but that's why when we're still calling them Descemet detachment, but they're not. They're pre-Descemet detachments, which behave differently to pure Descemet detachments. And that has to be recognized, and that is what this. And I'm really, really grateful to Rajesh Sinha and Sharon D'Souza, who provided a number of cases to prove the few cases that we had and the concept that we had, and we published this paper. So, and I always say that you give me the pathology that we have in India, and you give me the resources I have here, I can done my work in half the time. So collaboration is the key, I think. And if you start treating your detachments, I can send you an outline. We have prepared an outline to see how we treat our detachments, Descemet detachments, and what are the outcomes. And by looking at the classification in the way I've described, and then you can add on early or late, and you will find there are differences. So you can clearly define which ones are going to have a good outcome, which ones are not, and then how to get a good outcome even where those which are not. And that, I'm sure you people can come up with the answers much, much faster than we can, because we don't see these that often.
Sure, please, sir.
Good evening, sir. Lakshay here, sir. Thank you so much for the wonderful lecture, sir. So my concern is any changes in the pre-Descemet layer, Dua's layer with the age?
Yes, in fact, it gets thicker with age. There is a paper in the Transactions of the Ophthalmic Society of the UK by John Marshall. He has actually done a beautiful study on the electron micrographic features of the whole cornea, but he has looked at the changes over age. And he started with almost with a fetus or a newborn and all the way up to 8 years. And he's shown that the Descemet membrane thickens with age, as we know.
Yes, sir.
And he's commented on everything except the pre-Descemet layer. He hadn't even mentioned that, but if you look at his pictures now and you go and see, beautifully you can see in these transmission EM pictures that it is very thin in the younger the age, and becomes thicker like the Descemet membrane. It becomes thicker with age. We know now that it has more elastin than the rest of the cornea. I think it is also more under the influence of the endothelium than the keratocytes. So it is, and therefore certain dystrophies affect this layer, like macular dystrophy will affect the pre-Descemet layer, whereas granular and lattice don't affect the pre-Descemet layer. Macular dystrophy is supposed to be an endothelial problem. So there are changes with diseases, and there are definitely changes with age.
Yes, sir. And any change with in the diseases like keratoconus? One you mentioned that the posterior layer loses elastin.
Yeah, it loses the elastin and degrade. I think it stretches, and it's like it's a balloon, if you stretch it and you release the air, it comes back nicely. But if you keep a balloon, like your anniversary balloon or your birthday balloon, you keep it for a long time, and afterwards the air escapes slowly, and then it doesn't come back to its normal shape or size. It stays a bit flat, was floppy, is the word I'm looking for. So that's what happens, that in keratoconus, as it stretches and the cone becomes larger and larger, and it stays in the stretched position for a long time, then it doesn't come back. And when you do a DALK in long-standing or advanced keratoconus, you see a lot of circumferential striae in the descemet, because that large surface area is now trying to fit under the smaller surface area of the new graft. And you see more folds than you do in the relatively not so advanced keratoconus. So it definitely loses its, I think, the elasticity as well as its the collagen fiber stretch more, and they don't come back as much, quite apart from the elastic fibers.
Thank you, sir.
Dr. Dua, this is Vikas. So a fascinating lecture, and I was so happy to attend this. My question to you is that in cases of Descemet's detachments or pre-Descemet's detachment, where we see a tout kind of a layer, that happens post cataract surgery in some cases. While when we do demix or desex and we remove the Descemet's membrane in toto before we insert the grafts, at that time we don't see that kind of pre-Descemet's detachment in those cases, or we don't see any fluid seeping in the pre-Descemet's area, because as we understand that pre-Descemet's attaches with fibers to the posterior stroma well. So what is the difference, or what causes this difference, that when we are traumatizing the Descemet's membrane while removing or doing the, scraping the Descemet's membrane in DMEC and D6, as compared to the kind of Descemet's detachments or pre-Descemet's detachments that we see post-cataract surgery, which are tout and have fluid in the pre-Descemet's space above the pre-Descemet's layer?
Well, it's a good question, and I don't have an answer, but I can tell you that cataract surgery, as you said, is a common one, but even trauma and corneal graft surgery. In failed corneal grafts, you get this pre-Descemet's detachment. So clinically, those are the three areas where this happens. If you're only detaching the Descemet's membrane and your trauma of Descemet stripping is not that severe, then one is not expecting the PDL. And the PDL is relatively healthy in these eyes, whereas it should be even in cataract eyes. But the incidence is very low. If you look at all the hundreds and thousands of cataracts you do, the detachment, whether it's type 1 or type 2, is very, very low. So there is something there which makes it happen, but I haven't been able to put a finger on why that happens. But the detachments that you see we've got one or two cases where in DSEC we've got, in fact, in the paper we have published one case where we had done a DSEC and the DSEC was still attached, but the PDL had come off. So you can see a gap in the DSEC. So perhaps it can happen, but it's very, very, as you say, very, very low in frequency.
Thank you. Thank you, sir.
Good evening, Dr. Dua. I have a question regarding DMAC graft. So when we make a DMEC graft, do you think that if we don't separate PDL, that plain Descemet membrane, what we take for the graft, scrolls more. And when we take PDL along with that, it scrolls less because of the elasticity. Do you have any experience with that?
Yeah. If you're preparing a DMEC tissue, it will scroll a lot more than PDEC tissue. But almost the entire scrolling of the PDEC tissue is also because of the desmes. So when you take away the desmes from a PDEC tissue, then it doesn't scroll as much. So that's what we did that experiment and published in the AJO. So if you take PDEC tissue, you can measure the amount of scrolling, and then you peel away from that same PDEC tissue very gently. You can do that, the desmes membrane and the pre-descemet layer, and you put them aside. The desmes membrane will scroll a lot more, the PDEC tissue hardly anything. So in fact, in that paper, this is interesting, you know, how so many very big mathematicians and observers have said that the greatest contribution of Indians to mathematics was the concept of zero. And that is absolutely true, you know, how important that is. So when we did this study, the grading system for curling, how much the scroll is, was 1, 2, 3, 4. And we said the PDL, no, the control that we took needed a 0 because there is a grade 0 scrolling as well. And that was not, so we just said that classification of grading of scrolling has to be changed. You do need a 0 grade. And sometimes you'll find PDL, particularly from the older eyes, does not scroll at all, and you have to give it a grade 0. So any scrolling of PDEC tissue is due to the desmes, and all the scrolling, in fact, is the desmes. So if you have that splinting effect of the PDL on the desmes in the PDEC tissue, then it makes it much easier to unroll. And you can even physically unroll it with a spatula, if you like, without damaging the desmes or the endothelium, because it's got that buffering effect of the PDL stroma.
Thank you.
Although it's only 20 microns at the most.
Professor Deta, thank you so much for this fascinating lecture. I just had a question that about the DM detachment that you said, if it's a type 1 and we see it to be more taut, it can scar more, and therefore we might expect that the prognosis would be bad. But would you also suggest that if we do an early intervention in that case, before the scarring could come in, then does that behave similar to a DM detachment and give good prognosis, or does the PDL behave differently?
No, I think you're absolutely right, that what you say, and that's why I said the early and late is very important in that detachment. Now, the desmes membrane, because of the nature of it, it doesn't get infiltrated with cells, right? You don't get in the stroma of a desmes membrane actually cells. The pre-Descemet layer hardly has, in fact, I still believe it has no cells, and there may be the odd one to prove the rule. But in that patient that we showed, when we looked histology of 5 eyes, and we were able to show that there are 2 or 3 of them, there were no cells at all, but in one, particularly from the corneal graft, it's a long-standing detachment, there were no mononuclear cells, there were no polymorphs, there were no inflammatory cells, only the keratocytes had migrated in. And when keratocytes migrate, it becomes fibroblasts and myofibroblasts, which are going to cause scar tissue and shrinkage. So when it detaches, it still gives the appearance of a straight line against the back of the cornea like that. But when it shrinks, it becomes more tight. So if the surface area of that is more than the surface area against which it has to go, and it's lost its elasticity, it's not going to stay, it's going to come back. So the longer it stays, the more likely it is it's not going to. So you might have to do a desmetectomy to release that tightness and let it at least go back. So that is precisely the point that we want to do in this next phase of the study, in a multi-center study on treatment. So let us look at all the patients with detachment. Let us look at how long the detachment is and what type it is, and then do what we would normally do. So you either put SF6, you do desmetectomy or not. Some people put air. Do that and see what the result is. Then we will have a very good idea of how best to manage each type.
Thank you, sir.
Okay. Are there any questions from the audience who's looking out for that?
No, sir. We don't have any currently from all the platforms.
Okay. Anybody from the panel? Anything else? I think, Dr. Dua, it was again fascinating to have you, and always a pleasure. And I think all of us have gained a lot from your lecture always. And please do, as always, be a support to the iFocus teaching initiative that we have, which has become immensely popular with the postgraduates. And Dr. Santosh is the person, the brain behind it, and spearheading it. So look forward to your continued support, and thank you very much for being with us and taking out your valuable time to spread knowledge among the colleagues and postgraduates and fellows.
Yeah, but thank you. No problem at all with that. But it's much more fun to be there physically in Delhi than to be on a.
Sure. We love to have you there wherever. So that's not a problem. So I don't know. England is going through a new surge. So let's.
No, yeah, there you are.
Santosh?
Yeah, we started the vaccination, and I think in India also they've started. So good luck to all of you.
Yeah, they will start next week. I think Lodi or Makar Sankranti. I think they're looking for the auspicious days which start after 13th or 13th. So that I think they're going to start on 13th or 14th.
Good luck.
Yeah.
Thank you so much, sir. Good night, sir. Thank you so much. Good night.
Thank you. Thank you, everyone. Thank you, panelists. Thank you, everyone, support staff, Sunil, and all the fellows who have helped us. And thank you very much, Dr. Dua, once again. Thank you. Bye-bye.